Today, I'm going to demonstrate the suture shuttle technique, which is essentially an outside-in technique for repair of a longitudinal tear of the medial meniscus. We all know that there are various techniques all inside out, and outside in, and it has its own advantages and disadvantages. One of the major disadvantages of all inside and inside out technique is it is applied usually in either in the superior surface or in the inferior surface. And if you see what happens when you tie the knots, it opens into the inferior surface, both in the inside out as well as in the all inside technique. So when you apply these sutures, there will be eversion of the meniscus. That means the inferior surface has opened. So you need to put your suture into the inferior surface as well. So that is the reason why in 2013, Justin Salomon, he came up with the concept of a circumferential compression repairs, and in which he put a circumferential suture. This is just a diagrammatic representation in which he puts a suture through the periphery of the meniscus, through and through, and the center of the meniscus. Then he ties so that there is an all-out circumferential compression at the tear side. So since this requires a special device, and it can be applicable only in cases when there is a red-white zone tear. So we modified this technique of circumferential compression into a suture shuttle technique, which is essentially outside in repair of longitudinal tear of the medial meniscus. This is an animation which shows that it uses a very few instruments, epidural needle. Then you come from the capsule, pierce the epidural needle. Then from there you pass your Prolene suture. You take out this Prolene suture outside. That is why, and it is used as a shuttle suture. That is why this technique is known as suture shuttle technique. And using that Prolene, you shuttle the ethibond or orthocord, whatever you want to repair. So then you have to do a second pass to retrieve the other limb of the ethibond, which is still outside the joint. So again, the epidural needle is passed. This is inferior to the meniscus. So this needle is not going through the meniscus substance. Now you take it back outside the capsule. So once you pull it outside the capsule, so this is occupying the whole interior of the meniscus, or the medial flap of the meniscus, also known as the central flap of the meniscus. And when you tighten it, it provides a circumferential compression. So this is a video demonstration of the suture shuttle outside in technique. This patient had a medial meniscus peripheral tear along with the ACL tear. So very, very essential to identify the tear pattern, because there may be associated tear pattern. And this is, you can see a very nice peripheral bucket handle tear of the medial meniscus. In all of my cases, to prevent the cartilage from poking by the needle, I do a pie crusting, and you can see that the periphery of the meniscus is very nicely seen after doing a adequate pie crusting. Then the next step is to prepare the recipient part, which is essentially the peripheral part. So all the loose meniscus portions or the capsular portion has to be removed and make the bed bleeding so that the meniscus heals. The low suction shaving, so I do not use a suction in this case, but start shaving, and this abrades the capsule as well as the peripheral meniscus, so that the healing response comes from the periphery towards the center. Then my basic instrument to augment is a diamond rasp. So this is the diamond rasp, and then I use this diamond rasp to abrade the capsule and the meniscocapsular junction, essentially the inferior part of the meniscus, which is more vascular. From here, the healing response usually comes. So you have to abrade that part and clean that part so that your bed is very well vascularized. So then I put my scope is in the anterolateral portal, and I put a cannula, whatever you have, into the anteromedial portal. Then I pass my epidural needle. You can see the curve of the epidural needle can be very easily used and adjusted to pierce the meniscus. So here the meniscus has been pierced. I'm coming from superiorly and taking the central flap of the meniscus. Then the epidural needle through the epidural needle, the Prolene is being passed, and then it is retrieved outside the joint. If you curve your needle towards the notch, it will deliver the suture into the notch. So then you take it out through the cannula and then tie over a loop of the repairing suture. So in this case, it is an orthocord which has been used as a repairing suture. A very important step is to make a soft tissue tunnel through which your needle will go and the suture will come out. After a stab incision, use your mosquito so that you make a soft tissue tunnel. You have to go right up to the capsule so that you have a soft tissue tunnel and there is no interposition of the soft tissue or fat. Then you gradually pull your Prolene that will shuttle the suture. When it reaches to the meniscus, there will be little resistance. You give a jerky movement, it will come out very easily. Then a second pass is done through the inferior surface of the meniscus. So initially we have come from superior to inferior. Now it is coming directly from the inferior. And take note that this is not engaging any part of the meniscus. So it is just coming from capsule inferior to the meniscus. Then the other end of the suture, this Prolene is again retrieved outside the joint and it is tied over the loop and it is again shuttled. So that is why it is called a suture shuttle technique. So you use a suture to shuttle it. So now the loop is inside, which is holding the meniscus. It is very important to use your probe when you pull or push one limb of the thread, because it might just cut out certain fibers of the meniscus. So you can make use of your probe so that it prevents cutting of the meniscus by the thread. The second pass I'll show once again. So it is coming from up. You can come from up or down or up, whatever you want. But this time also we are coming from up. The needle is being passed. It's coming from the superior part of the meniscus through the capsule, then going into the capsule, coming down, and then the suture has been shuttled. Then we come from the inferior part. This is coming from the inferior. Again, note that this is not purchasing any part of the meniscus substance. Again, it has been taken out, tied over a loop of orthocord, and then the second limb is also shuttled out. So in this way, you can see that very nicely compressed vertical alignment of the suture, and this is afterwards. So then we approach to the tying of the knot. Once all the sutures are applied, we take the corresponding limb of the suture, which is coming out from one or two soft tissue tunnel, which is made in the medial part of the knee. Then I apply a sliding SMC knot. If you see the exterior view, there is a sliding knot is being applied. And if you see the interior view, we are still using the probe so that your gliding of the suture will be controlled by the probe, and there is a less cheese saw cutting effect into the meniscus. So here we have been pulling the sliding knot and the knot is being tied. So looking it inside, you can adjust your tightness, and then you send one more knot that will lock your sliding screw. So you can see that these are the vertical sutures, and this is the final one after the repair. You can see very nicely circumferentially compressed suture. So the advantages of this technique is it is a low cost, since no costly implants are required. It is low cost, that can be done with locally available material in every operation theaters. Both vertical and horizontal mattress sutures can be applied. It provides circumferential compression, that is very, very important. And this technique is very easily reproducible and can be used to repair the longitudinal tear of any part of the medial meniscus or even the lateral meniscus. Some disadvantages are pie crusting of superficial MCL is almost always required in this case, because you need to have your needle passing and not injuring the cartilage. Orientation of sutures may not be vertical in posterior horn repairs. If it is really posterior, the suture may not be vertically oriented. It may be little oblique, and relatively larger knot that passes through the meniscus may cause injury to the meniscus itself. So it is recommended to use a thinner sutures materials. Thank you very much. The detail of this technique has been published in Arthroscopy Technique, and it is available free for everybody to watch. Thank you very much.